Hey guys, it's Val here, third year medical student, currently on my Obs Gyn rotation. And today I'm going to be talking about postpartum hemorrhages, which is also known as PPH and is the major cause of maternal morbidity and mortality worldwide. This is basically where you have a bleed after baby is born. So let's jump right into it. So a postpartum hemorrhage is anything that can kind of cause hemodynamic compromise usually. So a minor PPH, which is less than 500 mils, isn't really of concern. A severe PPH is anywhere from 500 mils to 1 liter of blood loss, or blood loss that is significant enough to cause hemodynamic compromise. Then you can have a massive postpartum hemorrhage, which is where you've lost more than 1 liter of blood, which can cause life-threatening blood loss and may result in the need for a blood transfusion. Now, PPHs can either be primary, which is they happen within 24 hours of delivery, or secondary, which is where they happen anytime from 1 day to 6 weeks after delivery. Now, there are 4 main causes of postpartum hemorrhage, or at least 4 main categories of postpartum hemorrhage, and these are tone, trauma, tissue, and thrombin. Tone mainly refers to uterine atony and makes up the majority of PPH cases, where your uterus isn't contracting properly, and thus there's excessive bleeding. You can have trauma in about 20% of PPH cases, which refers to genital tract trauma. You can have tissue in about 10% of cases, which refers to retained pregnancy tissue within the womb that's causing bleeding, or thrombin, which refers to less than 1% of cases and is used to refer to coagulopathies, so a person with an increased bleeding risk, which is leading to a postpartum hemorrhage. Now, starting with uterine atony or tone, this is the first thing that you check for when someone's bleeding. So you feel the abdomen and you feel for the tone of the uterus. And if the uterus feels boggy, it's likely that it's lacking tone. So the reason that we want increased tone after delivering a baby is because imagine the microscopic view of this uterus wall. The uterus wall is actually filled with all of these myometrial vessels, which usually supply the placenta and various aspects of the uterus. And when the uterus is contracted, so imagine it's contracted down here, these vessels are basically clamped shut to prevent bleeding. However, for various reasons, the uterus might not contract properly, and this can result in a PPH. So the causes of atony can be summarized using the acronym AEIOU. And A stands for anatomical abnormalities, such as leiomyomas or fibroids, which if you imagine if this uterus has a massive fibroid in it, it might not be able to contract down, and thus those vessels will continue to bleed. E stands for exhausted myometrium, which can occur in the case of too much oxytocin or a rapid or prolonged labor. I stands for infection, which is marked by pyrexia or fever, and often occurs in the case where a person has ruptured their membranes, but they haven't given birth within 24 hours of that ruptured membrane. And so because the amniotic sac is broken, a intrauterine infection is more likely to be introduced. And then OU stands for overdistended uterus, which can happen in the case of a person that's had multiple pregnancies or perhaps multiple babies in a pregnancy, or if you have excess fluid, so polyhydramnios, or a large baby, such as in gestational diabetes, known as macrosomia. So all of these factors can contribute to a uterus's inability to contract and clamp down, and hence can cause a postpartum hemorrhage. And again, this is 70% of cases. Now, in order to manage this, a couple of things are done. So if a boggy uterus is felt, the midwife or doctor can press down on the womb externally and manually massage the fundus of the uterus in a circular motion, which encourages it to contract. They can also insert a hand into the vaginal canal and bimanually, so double-handedly, compress the uterus to help contract it. Then you can administer uterotonic agents, aka medications that increase the tone or contractility of the uterus, such as ergometrine intramuscularly. You can also give IV oxytocin, also called syntocinon, and then you can give prostaglandins, so misoprostol parectally, and tranexamic acid. So tranexamic acid doesn't have anything to do with the tone of the uterus. This one here is basically it makes your platelets sticky and hence helps the blood to clot, preventing further blood loss. So that's tone. The next T is trauma. This refers to any genital tract trauma which can be caused by episiotomies or lacerations due to, for example, forceps use during a vaginal delivery. It can be due to uterine rupture, for example, in the case of multiple cesareans where during labor the cesarean scar might rupture and bleed. Or it can also be due to uterine inversion, where the uterus itself kind of inverts or kind of descends through the vaginal canal. So the management for trauma, obviously, is to basically inspect the perineum and the vaginal canal under really good lighting. So have a look inside, lay the lady flat, and immediately repair any lacerations that might be identified. Now the third T is tissue. So this refers to retained pregnancy tissue, and I've drawn a placenta here because the most common cause is retained placenta or abnormal placental separation. And this is more likely in the cases where someone has placenta previa, where the placenta is covering the internal os of the cervix, or placenta accreta, where the placenta is invaded into the myometrium and thus doesn't separate nicely, or if the person's had prior surgery or is of advanced maternal age. The way that we can prevent this retained pregnancy tissue is through what they call active management of the third stage, that is, controlled delivery of the placenta. So remember, the first stage of labor is the dilatation, the second is the delivery of the baby, and then the third is the delivery of the placenta. And if we deliver the placenta in a controlled manner, there's less likely to be retained placental tissue. So the way that they do this is that they prophylactically administrate oxytocin, remember uterotonic, with the delivery of the baby's anterior shoulder. Then after the baby's out, they perform controlled cord traction, which is where they gently hold the uterus and pull down on the cord so that it separates from the myometrium in a gentle way. And then they externally compress the uterus and use a bimanual massage to help expel any further clots or any retained contents. And then they clamp and cut the umbilical cord quickly and early. Now the last cause of PPH, the last T, is thrombin, which happens in less than 1% of cases. And you can't really determine whether or not a person has a coagulopathy in the moment. It's something that has to be done on history taking. So you have to find out whether a person has a coagulation disorder, such as von Willebrand disease, hemophilia. They might also have thrombocytopenia or reduced platelets due to preeclampsia. So you might check that whether they've had high blood pressure or their platelet counts during their pregnancy. They might be on any anticoagulant drugs, such as, for example, heparin or warfarin for various reasons, such as if they've had a venous thromboembolism. Coagulopathies also covers intrauterine fetal death, infection, and amniotic fluid embolism. Now, once you've kind of gone through the process of looking for uterine tone, checking for trauma, checking for tissue, and checking history for thrombin, the way that you would manage this further is to insert an indwelling catheter because you want to monitor fluid output, document the blood loss so that you can classify whether or not this person needs transfusion, and collect a group and hold as soon as possible so that they're ready for transfusion if needed. Now, if none of these kind of techniques work and the person is still bleeding, you can perform surgical intervention. So one example of this is an intrauterine balloon tamponade, which is where a deflated balloon is inserted into the uterus and then inflated to manually compress the uterus from the inside out. Another surgical intervention is uterine artery embolization, which is basically where they clip certain parts of the uterine artery so that there's reduced blood supply and hence less bleeding and less PPH. Another thing that can be done is a B-Lynch compression suture, which is basically the name for inserting a suture that wraps around the uterus, and when it's pulled tight, it manually clamps the uterus down and keeps it contracted, hence preventing bleeding. And ultimately, if none of these techniques work, the ultimate end stage is to perform a hysterectomy as kind of the definitive and finite treatment for PPH. So yeah, that's PPH, postpartum hemorrhage, in a nutshell. I hope it makes sense. And again, it's really important to know that this is the main reason why women might die during childbirth, is because of this blood loss. So being able to know all these steps and knowing where to get the medications, how much to give, is a really, really important part of understanding labor and childbirth. So thank you so much for listening. I hope that makes sense, and I'll see you next time. Bye!